So next in the line of discussion will be a thyroid swelling, history taking and examination. So thyroid swelling is a case. When I was an undergraduate student, I used to dread taking thyroid as a case. Okay, I really found it very difficult, and I think most of the students find it difficult. I was not an exception, but let me assure you, it's nothing difficult here. And after you listen to this discussion of mine, I'm sure you can proceed very confidently in presenting a case of thyroid swelling. So let's proceed. So next in line for discussion is examination and history taking for a thyroid swelling. So when a patient of thyroid swelling presents to you, what are the things you will inquire in history of the patient? Okay, let's have a look. Undoubtedly, you will know the particulars of the patient, the age, sex, occupation, residence, and then a few questions should be asked about the swelling itself. Now, what's the importance of residence? Why is residence important? Because in some areas where there is a deficiency of iodine, thyroid is endemic goiter. You find endemic goiter in such areas. Here I would like to point a very important thing, that even calcium is goitrogenic. And in areas which are rich in lime also show a rise in goiter, enlarged thyroid. And these are generally, for example, Derbyshire and Yorkshire, not in India of course. But the fact is that you should know that calcium is also goitrogenic, and the importance of residence in history taking of a thyroid swelling. Now, what are the things you will be asking particularly for the swelling? This you can also infer from the discussion of examination of swelling which we have already had. But again, I am going to brief you the things you need to ask for particular to the swelling. So for the swelling, you will ask the onset, the rate of growth, duration, since when the swelling is present, whether any pain is present or not, and you must ask about any symptoms of primary or secondary thyrotoxicosis. Now, what are the symptoms that signify towards primary and secondary thyrotoxicosis? I'll be discussing later. But you need to know about the symptoms. You need to inquire if the patient has complained of symptoms which point towards primary or secondary thyrotoxicosis or mixed edema. Also, any pressure effects due to the swelling, like is the patient having any dyspnea or dysphagia or hoarseness? Okay. And here, then if you ask the past history of the patient, you must inquire about the course of treatment, the drug history, etc. Now again, when you ask about pain, and if the patient says that yes, he has a thyroid swelling which is also painful, what are the things that should come to your mind? First thing that should come to your mind, that it may be an inflammatory swelling of the thyroid, or malignant swelling when infiltrates the nerves can also produce pain, or sometimes a simple thyroid cyst. If a hemorrhage occurs inside the cyst, it may be painful. Alright? So that's what you can infer from presence of pain in a thyroid swelling. Okay, let's proceed further. After the history taking, you proceed towards the general examination. And here you should have a look at the build and state of nutrition of the patient. The feces, pulse rate, and skin, whether it's moist or dry. Build and state of nutrition. Like if the patient is thin or obese, this may point towards hypothyroidism, and if the patient is thin, may point towards hypothyroidism. Okay? Those suffering from hypothyroidism will have a puffy and dull face. Talking about the pulse rate. Talking about the pulse rate, if it's less than 90 or 90 to 110 or greater than 110, we can say it's mild, moderate or severe thyrotoxicosis. Okay. Similarly, skin, whether it's moist or dry, if it's moist, you should suspect hypothyroidism, and if it's dry, you should suspect hyperthyroidism. So those are the important points that you should know in the general examination. Let's proceed towards the local examination, the inspection and palpation of the swelling. Now, local examination of a thyroid swelling shall be carried out similar to that for any other swelling. Okay, but here in discussion, I will be highlighting the most important points that you have to keep in mind. First of all, you need to know what is Bezilo's method for inspection of a thyroid swelling. Bezilo's method. For that, you need to see this picture. So what do you appreciate here? This lady with a thyroid swelling, she is putting her hands behind the occiput, and you have to ask the patient to try to push her head back. Okay, so what happens is this highlights the thyroid swelling, and the thyroid swelling becomes more prominent. Okay, so this method has to be applied while inspecting the thyroid swelling. So now, when you have asked the patient to be in such a position, what are the things you'll be looking for? In other words, what are the things you will have to note down while inspection of a thyroid swelling? Very quickly, I'll be jotting down the points that you need to note down while inspection of a thyroid swelling. Okay, so what are the things that you will be seeing? Quickly, you have to appreciate the size, shape. Because it's inspection, you don't need to measure, you have just to make an approximate measurement. Okay, so you have to know the size, shape, position and extent of the swelling, right? Apart from that, you have to say about the edge, the number of swellings, the surface of the swelling, as you can appreciate, and the skin over the swelling. Apart from all this, the main thing that you need to see here is movement with deglutition, because this, if present, confirms that the swelling is of thyroid origin. Movement with deglutition, because if this is present, you know that the swelling is thyroid swelling. It almost confirms your diagnosis. Okay, now when you have asked the patient to swallow, okay, you will see the thyroid swelling move up. At this point, you need to note if you can see the lower border of the swelling or not. This is very important. Right? Now, why is that important? Because if you're not able to appreciate the lower border of the swelling, you should suspect the presence of a retroesternal goiter. Okay. Now, if you're suspecting the swelling to be of a retroesternal goiter, I mean you cannot appreciate the lower border of the swelling, you need to perform one more test. Or you can say you need to look for a sign, which is known as Pemberton sign. What is Pemberton sign? Now, for Pemberton sign, what you need to do is you ask the patient to raise his both hands by the side of his head and maintain that position for quite a while, like at least 1.5 minutes. So what happens is, if there is a retroesternal goiter is present, you need to see first the diagram of a thoracic inlet. See, you can see it's a narrow space bounded interiorly by manubrium sterni, the first rib and the first thoracic vertebra. It is a narrow space. Okay, many structures are already present here, and especially the vessels in the anterior portion. Now, if there is a retroesternal goiter present, it further makes the space more congested. And when you ask the patient to lift his hands, the ribs are elevated, further narrowing the thoracic inlet. So this leads to congestion of the face due to engorgement of the veins. Okay, so this, if a retroesternal goiter is present, the person, after raising his hands for quite a while, you will note that there is congestion of face. Okay, or you can see engorgement of veins in the neck. That will confirm the presence of a retroesternal goiter. Okay, so once you have completed the inspection part, you will proceed towards palpation of the thyroid swelling. Okay, so what are the things you're going to do there? Let's have a look again. So first of all, you need to know how to examine, or better say how to palpate a thyroid swelling. Now, this is a pic taken from S. Das' book, clinical book. Okay, and see what is being shown here. Here you can see that the method to palpate a thyroid gland is from behind, where you flex the neck slightly. You flex the neck of the patient slightly, put your thumb at the occiput, and you palpate the lobes of the thyroid with your 4 fingers of both the hands. That can give you a better appreciation of the edge and mobility of the thyroid gland, right? But it's not that you only have to palpate the thyroid gland from behind. There are other methods also, which I'll be showing here. Okay, so as I have just shown a pic, that first of all you need to palpate the thyroid gland from behind by flexing the neck slightly. There are also other 2 methods for palpation of the thyroid gland, and they are named as Lahey's method and Kreil's method. Now, what is Lahey's method? This picture is again taken from Esther's book. Now, what is Lahey's method? Lahey's method is used for better palpation of each lobe of the thyroid gland. When you have to palpate the right lobe, you have to push the right lobe towards the right with your right hand, and then you can better palpate the swelling from your left hand. This will make you appreciate better the characteristics of that lobe. Okay, so that is Lahey's method. You push the lobe to one side, I mean to the same side, and palpate it with the opposite hand. Okay, that is Lahey's method. And the method of palpation here will be Kreil's method. So another method of palpation here is Kreil's method. Now, Kreil's method will be applied when the swelling is very small and you cannot appreciate it very nicely with your hands, the size being small, of course. So what you do is you put a thumb over the swelling, and then you can better appreciate it. You can appreciate its movement and deglutition also, and also the characters of the swelling. So that will be when you have a smaller swelling, you will apply the Kreil's method for palpation in a thyroid gland. Okay. So when you have known the methods that you have to use while palpating a thyroid gland, let's move further and see what are the things you will be noting down. Now, palpation of a swelling. Here also you need to note down the temperature, tenderness, size, shape and extent, the surface of the swelling, the edge, the consistency, right? And of course its fixity or mobility and relation to the surrounding structures. These are the things you'll be noting down in case of a thyroid swelling. Other features that I have explained in examination of swelling video, where other characters like fluctuation, fluid spill, translucency, etc., these are not relevant in case of a thyroid swelling. Okay, so now when you are feeling the surface of the thyroid swelling, it may be smooth, it may be bosselated. A smooth swelling points towards generally colloid goiter. And bosselated you may find in case of multinodular goiter. Similarly, consistency. So talking about the consistency, it will be firm in case of Hashimoto's, softer in case of colloid goiter, and hard in case of riddle thyroiditis and anaplastic carcinoma. Similarly, you must check for fixity of the swelling, and if it is fixed, it is again pointing towards either Riedel's or anaplastic. After noting down the general points of examination of swelling, you have to look for pressure effects, if any, due to the thyroid swelling. Now it can press on trachea and lead to stridor and later dyspnea. Okay, how do you test for this? We have a specific test for this, and it is named as Cochet's test. Let me show a pic of it. So what you do in Cochet's test is you put a slight push on the lateral lobes, okay, medially, so that it compresses the trachea further. And if already the trachea has been compromised due to the thyroid swelling, this test will produce a stridor, and that will be a positive Cochet's test, and you can say that yes, the trachea is being pressed upon by the large thyroid swelling. Okay, so you have to remember the name of the test, which is Cochet's test. Next, it can again cause deglutition, difficulty in deglutition also due to the pressure effect. That is dysphagia. However, in case of a thyroid swelling, it is not a true dysphagia. What happens here is that whenever you swallow, the thyroid gland is pulled up, and you may find a uncomfortable feeling during swallowing, but it is not a true dysphagia. Nonetheless, you have to inquire about any such symptom, and that means the swelling is so large that it is pressing upon the esophagus too. Okay. Now, it can press upon the trachea, it can press upon the esophagus, it can also involve the recurrent laryngeal nerve, and then it may produce hoarseness. So you have to inquire about any recent change in voice, right? So a quick revision, you have to you inspect the thyroid swelling by Pizzello's method and jot down the important points. You see a movement with deglutition, you see if it's a retrosternal goiter or not, then you proceed towards palpation and you involve the Lahey's method and the Cryers method, right? And you note down the points important in palpation of a thyroid swelling. You must inquire about the pressure effects, any pressure effects of the swelling, and rule that out with Kocher's test and other things, right? After you have done all this, you must do the examination of cervical lymph nodes, if they're enlarged or not. Okay, these may be enlarged in case of malignant swellings, and therefore it is a very important examination which should not be skipped. Now, inspection completed, palpation completed. Is there any role of percussion in a thyroid swelling? There's only one and only one point, that you may percuss on the manubrium sterni, and you may find a dull note if there is a retrosternal goiter. However, these are more of theoretical importance rather than actual practice. Similarly, if we have to talk about auscultation, you may sometimes find bruit over the swelling due to increased vascularity in cases of a toxic goiter. In case of toxic goiter, you may find some bruit over the swelling. Okay, so that completes your local examination of a thyroid swelling. Next, we'll be talking about systemic examination relevant in cases of thyroid swelling. So now when we proceed towards the general examination or the systemic examination, in these cases we have to look for symptoms of primary thyrotoxicosis, if any, symptoms of secondary thyrotoxicosis, and if any symptoms are present that signify metastasis due to the malignant swelling, right? So let's see what are the symptoms that pertain to primary thyrotoxicosis. Here you will be getting some certain eye signs: tachycardia, tremor, moist skin, and thyroid bruit. Now, tachycardia you will be examining when you see the pulse of the patient. You don't need to separately examine it again. Similarly, moist skin also is included in the general examination, thyroid bruit in the auscultation part of the local examination, right? So we'll be seeing in detail the eye signs and how to see for tremor in a case of thyroid swelling if you are suspecting it to be that case of a primary thyrotoxicosis. First, have a look at the eye signs. Now, the eye signs include lid retraction, exophthalmos, ophthalmoplegia, and chemosis. Now, lid retraction. Lid retraction occurs due to overactivity of the involuntary part of levator palpebrae superioris and therefore the upper eyelid appears higher than the lower eyelid. Now here we need to look this picture very closely. This picture is again taken from our book Estas Clinicals. See, this is the normal position of the eyelid. Okay. Would you appreciate the upper eyelid covers the iris to a certain extent, and the lower eyelid is almost in the lower margin, right? But in lid retraction, you can see the eyelid has moved a bit upward so as to cover the up to the upper margin of the iris, right? And when there's exophthalmos, you can see the sclera between the eyelid and the iris, right? So that's the difference between lid retraction and exophthalmos. This is very important to understand. Now after lid retraction, and the sign is lid lag. Lid lag means that the upper eyelid lags behind the eyeball. It cannot keep pace with the eyeball. When it sees a finger moving from forwards to down, from above to down. Okay. And this is also known as von Graeff's sign. So von Graeff's or the lid lag sign. Here what happens is that the upper eyelid cannot keep pace with the eyeball. When it looks following an examining finger, move downwards from above. Again, let me show you a picture here. See, this picture shows us von Graeff's sign. What you see here is that when the person is looking down, one of the upper eyelid lags behind the eyeball, right? You can see the difference between the two eyes. So that is von Graeff's sign for you. Next, we will be talking about next sign is exophthalmos. Now there are various other eye signs here, and we will have a brief look at them. First, we should discuss about the Joffrey's sign. What is Joffrey's sign? See this picture. Now to elicit Joffrey's sign, what you have to do is you ask the patient to look upwards, keeping head fixed. Okay, head must be fixed, and ask the patient to look upwards. What you see here is that there is absence of wrinkling on forehead, no wrinkles. You don't see any wrinkles on the forehead when this person tries to look upwards, and that is Joffrey's sign, and it is one of the eye signs of thyroid ophthalmopathy. Next is a Stelvak sign. This is a Stelvak sign for you. Stelvak sign, or staring look, you can say, is another sign of primary thyrotoxicosis. You can see, you can again here see the sclera is visible between the upper eyelid and the iris, right? Similarly here also. So that is Stellwax sign. Next is Mobius sign. And this is inability to converge the eyeballs. For this, you ask the patient, suppose this is the patient here. You ask the patient to fix his gaze on your finger, and you move the finger close to his nose slowly and ask him to follow your finger. You will see that the patient's inability to converge the eyeball as the finger is brought nearer to the nose, and that will elicit the Mobius sign. Okay. So similarly, in fact, there are many eponyms on the eye signs of primary thyrotoxicosis, and I can make a separate video on it. Maybe I will make a separate video on it. But for the basic, these many signs are enough to begin with. You must know almost this much sign. Okay. Now the next thing that you are looking for in primary thyrotoxicosis, apart from eye signs, is tachycardia, as I had said earlier. Tachycardia and tremor, moist skin. Right, and bruit. So you know all these things, how to look for. Let's see how to find out tremor if present. So see, when you have to elicit the presence of tremor in a patient, you ask the patient to stretch out his hands, and because tremors, if present in primary thyrotoxicosis, are very fine tremors, you may not appreciate it with your eye very clearly. So what you do is you put a paper on his hands, on his outstretched hands, and if the fine tremors are present, you will see the paper moving, or you can say trembling, due to the tremors. Of course, you have to put the fan off. Don't forget to put the fan off, right? So this way you can elicit tremor if present in a primary thyrotoxicosis patient. Then to rule out secondary this completes your examination for primary thyrotoxicosis symptoms. To rule out any symptoms of secondary thyrotoxicosis, as we all know that secondary thyrotoxicosis mainly affects the cardiovascular system, so you should rule out presence of any cardiomegaly, any fibrillations. For that you will have to do an ECG, and of course you can examine the pulse, and sometimes even edema of ankles may be present, orthopnea, dyspnea, etc. And once you have noted the symptoms of secondary and primary thyrotoxicosis, you must check out for any symptoms of metastasis if present. You must examine the spine, the skull for bony mets, and for examination of lung for any metastasis in the lungs. And with this, you complete your examination of a thyroid swelling. Okay, thank you. And therefore the upper